Thank you. Can you hear me? Not too loud?
We hear you.
Okay, good. All right, I'm just going to walk around. This is a little weird, little echo. So I think some of the topics may have been covered already, but I'm just going to start off this presentation by just giving a quick overview of how we think about this disease, what some of the factors are for initial treatment, because that does get into whether we think we want to do a transplant or not. And then the types of transplants and some of the cellular therapies that are coming around and what their roles are. Okay. So again, multiple myeloma is about 30,000 new cases diagnosed in the United States. And generally, this is a disease of aging. As people get older, we see it more common in men and in blacks. And we're seeing more and more patients living with myeloma. And here you can just see from SEER data that the majority of patients who get this disease are in their 60s and 70s. But we are getting much better at treating this disease, and there are more people living with it. So these are just some survival curves that are really encouraging. So you can just look to see all the improvements that are being made by the community in treating this disease. So just as far as diagnosis, whenever you get diagnosed with a plasma cell disorder, it can be at various stages. It can be very early, what we call a monoclonal gammopathy of unknown significance. Oftentimes, this is picked up by primary care physicians when they're doing routine blood work and they see elevated protein in the blood. And that leads to a referral to a hematologist. And basically, there's some extra bone marrow plasma cells, but patient feels fine. There's really nothing wrong with them. And so we often watch these patients for years and years and years. But there is a risk for conversion over to a more advanced disease, to what we call a smoldering disease, where things are a little bit worse now. But still, there's no evidence of organ damage, so really it becomes very controversial. Should we treat these folks or not? And that's where talking to a myeloma specialist would be helpful. And then eventually conversion over to multiple myeloma, and I think the key feature here is organ damage. So we use these criteria called CRAB or SLIM CRAB, so high calcium, R for renal or kidney dysfunction anemia, where the bone marrow plasma cells are expanding and crowding out the normal bone marrow cells and preventing them from doing their job, and bone lesions, which is always a feared complication. We don't want to break bones. And there are better ways of picking up these things nowadays. Our tests are better. Blood tests are much more sensitive. We have more sensitive imaging methods. So for example, on an X-ray, you can see something once it's developed into a significant size, but an MRI often can pick stuff up when it's still small. So how do we select our initial treatment? Well, we have to define what the goals of therapy are. If you have smoldering disease or if you have MGUS, well, you probably don't need any therapy. But if you have active myeloma, well, we need therapy. So what is our goal? Well, we want to achieve effective disease control. We want to do that for as long as possible. We want to help patients live longer. We want them to live well. It's okay if you're treating the disease, but you're in bed all day. That's not cool. So the regimen needs to be well tolerated. We need to prevent some of the complications of organ damage from the disease. All the current evidence suggests that the harder we go at this, the deeper we get patients into remission. The depth of that remission is important, and it prolongs the period that patients are in remission. Obviously, there are caveats to this. For each individual situation, it can be different. But generally, we try to get the myeloma down to as low as possible and keep it there for as long as possible. So some of the factors that we think about: age. Again, most patients are older when they have this. So how is that going to affect your decisions on selecting therapies? What we call performance status, how healthy are they? So, you know, we have 80-year-olds that are running marathons, but some 40-year-olds that can barely get out of a chair. So that's important in considering your treatment. What comorbidities patients have, these are other medical problems that you can come in with. So if you have severe heart failure, obviously that can impact what kind of therapies you might be eligible for. You heard a lot about risk stratification and some of the molecular features of how myeloma is risk stratified, so that's important. Transplant eligibility, and we're going to talk a lot about that. What makes somebody eligible for transplant? So I'm biased, I'm a transplant doctor, so everybody's eligible for transplant in my book, right? So, so I always look about why isn't someone eligible for transplant. I look for reasons. Am I going to hurt them by doing this procedure? So other disease-related complications, toxicities, you know, how familiar is your doctor with the combinations of therapies, potential for combining several drugs together. Cost often comes into play in making decisions, and also ease of schedule. Say someone's traveling a lot for their job and they like a particular schedule, that might impact which therapies that you do. So, and here's just a little bit of a history. So I think I was going to medical school like in the early, around that 1999 period. So thalidomide was just coming out then. And before then, all I knew about myeloma was that we gave these two drugs, and it was called melphalan and prednisone, and that was really it. But now you can see all these other drugs have been developed, and it's really changing how this disease is managed. It's gone from a disease where people had it and they were in trouble within a year or two, to now a really chronic disease. I often tell my patients, it's like being diagnosed with diabetes. That can be just as bad, you know. And as long as you're on therapy and managing it, you can live with it for a very long time. Transplant is not a new therapy. It's been around for a very long time. We just know how to do it much better nowadays. So we can get people through this therapy very easily now. And despite all these drugs, we still think that it plays a role in the management of myeloma, because studies continue to show that patients benefit from upfront transplantation, and it can decrease the burden of disease in most individuals. And some of the other types of, we'll talk about some of the types of transplants coming up, but one of the type of transplants that we do is called an allogenic transplant, where we use someone's immune system to actually help eradicate the myeloma, and that has led to the birth of sort of immunotherapy, and there are some new options coming along the pipeline there. So what are our current treatment approaches? Generally, we use a triplet regimen for most individuals. Again, there's some variability around this. For each individual patient, it's going to be a little bit different, but that might change soon, and we might be using 4 drugs for people, where we add an antibody. Typically, we do that for a couple of rounds, and then the patient is referred to a transplant center and usually undergoes a transplant. You can have 1 transplant. 1 is good, 2 is always better. Not necessarily the case, but there might be some cases where you might want to think about that. And then after the transplant, consideration of maintenance, typically with an IMiD or proteasome inhibitor. And you ride that for as long as you can, and at some point patients will relapse. And then you can kind of repeat the whole thing again, or consider an allogenic transplant. There's a transplant from a donor. Those we only do in certain situations, or a clinical trial testing a new experimental therapy. So I think this is a nice diagram, just kind of showing you graphically how I think about this. So when patients are diagnosed, they're kind of at the top of this iceberg. Yeah, they got lots of disease in their body. And this is our kind of standard detection ability. So anything beyond this at the bottom of this iceberg, it's hard for us to see. There's still plenty of disease here, right? But this is when your bone marrow, below here, when you get to CR, it says your bone marrow looks clean, that there's no plasma cells. right? Complete remission. And we know that being in complete remission is not the same thing as a cure. A cure is really getting all the way down to the bottom and having nothing there, no myeloma cells, and nothing ever is going to come back. So we want to drive down this as close to cure as possible. And we think the best way of doing that is doing some of the things I just talked about in the previous slide, is coming in with multiple drugs up front, doing a transplant, and then doing maintenance. Again, this is variable depending on what type of risk of disease that a patient has. But in general, this is the approach that we take. So now getting to transplant and myeloma, just a background of transplant. We're very simple people, transplant doctors, so if some chemo helps, let's just give a boatload more, and that's going to work better. At least that's the idea. So it's based on the intensity of chemotherapy, and what prevents us from just keep giving more and more chemo? Well, really, the bone marrow has a tolerability for chemotherapy. There's lots of cells that are being produced in the bone marrow. It's the organ that makes blood for you. And beyond a certain dose of chemotherapy, the bone marrow will basically die. And so you can only give a certain amount. And what we know is in the bone marrow, there live these things called stem cells. They're like seeds that we can harvest from the bone marrow. We can freeze them away, and we can put them back into somebody, and they'll grow a new bone marrow. So these seeds, we can keep them around forever. So that got doctors thinking about this idea, well, myeloma lives within the bone marrow. Let's give this drug called melphalan, which targets that organ very well. Let's kill everything, but just let's support those patients with stem cells to make sure that their bone marrow doesn't die permanently. And that's essentially what the autologous stem cell transplant is. So how do we collect these stem cells? Well, in the old days, when it first started, we used to poke needles into the hips and collect all the cells from the hips, because that's where the stem cells lived. But nowadays we don't do that, mostly because I don't know how to do it anymore. It's been a long time since I've done one. We use growth factors. These are substances that your body normally makes, and it coaxes cells to come out of the bone marrow out into the blood, and then they can be harvested from the blood. So typically we try to collect enough for at least 2 of these procedures. So how do we do that? Well, again, this growth factor called GCSF, that's the most commonly used at our center. And then we can add another growth factor called plerixafor. So for people where this one doesn't work, we add the second one, and pretty much at our center, I think we've failed to collect one person. So almost everybody gets their cells collected using this approach. Some people, they are a little harder to collect, and then we can add a little chemotherapy called Cytoxan. And the disadvantage with this is the timing is not as good, so we never know when we have to put somebody on the machine to collect. So we prefer this approach with the growth factor alone. The patients prefer it too. So, okay, one of the pictures disappeared here. So this is the machine that we use to collect the stem cells. So this machine uses the principle of centrifugation. So basically blood is sucked out of your veins, put into this machine. It spins the blood really fast, separates the blood into its components, and then the stem cells are floating on top, and that gets diverted into this bag. So this contraption here does a lot of fancy stuff, and I don't really know how to set it up, even though this is what I do for a living. But we have great nurses that know exactly what to do with this, and it magically just happens. So, but this is not new technology. This has been around forever, but this machine uses all sorts of fancy lasers and does it very well. So, oh, there we go. And this is an older picture, so this machine's a little bit older, but the principle is the same. So this is generally what it looks like when someone's undergoing a stem cell collection. So everybody gets kind of scared about stem cell transplant and what it gets involved, but it's really an outpatient kind of procedure. So not a big deal. Okay, so There have been a lot of advances in this procedure, and that's why we can even do this as an outpatient in most individuals. So there's more specialized nursing care. So we have trained nurses at our center who just know how to do this. We can decrease some of the side effects. Simple things like chewing ice while you're getting your chemotherapy decreases some of the mouth sores that you get with this. We got great antibiotics that helps us prevent infections. We use less chemotherapy as part of our mobilization of the stem cells, so that helps patients go into the procedure in better health. And again, like I said, whenever we can, we try to do this procedure as an outpatient. So the entire time you're at home and just coming into our clinic for infusions and supportive care. But that's not possible for everybody, so we also have an inpatient unit where whenever we need to, we put patients in. So again, let's get to that question of eligibility. Again, if you can walk into my office, you're eligible. At least that's my criteria, but there are other criteria that we look at, like how well your organs are working. Again, are we going to hurt you with this procedure? We don't want to do that. We want this to benefit the patients. We want it to lead to longer periods of remission. So again, we look at how healthy are they? What kind of other medical problems do they have? What kind of support do they have? And I think we do a great job in the Austin community. I can tell you we transplanted somebody who was homeless, and we got him as much support as we could. Mary Peterson, who's in the audience, helped with all of that. So, whenever we can, if we think the patient's going to benefit, we really go to the nth degree to get them through this procedure. The other question that often gets asked is, well, you showed that slide up front. There are all these new treatments. Is this still worth doing? Because this sounds kind of like it's old. And, there's a lot that's involved. And we do think, based on all the recent studies, that yes, it does still have some benefit. Even in the era of what we call the novel agents, all these new drugs like Revlimid, Kyprolis, Velcade, that when we combine those therapies with the transplant and maintenance, that's how we get to that bottom of that iceberg, as close to the bottom as we can. And this is, I think, the only slide like this that I'm going to show, which basically shows, this was a study, a large international study done, which looked at one of the standard treatments, Revlimid, Velcade, dexamethasone, either given alone or in combination with transplant. And what you can see is a separation of the survival curves where patients who've had transplant do better. But we still have issues with utilization. It's a good treatment. It's high-dose melphalan chemotherapy with stem cell support. It's one of the most effective treatments for myeloma, and it's still underutilized. Why is that? Well, again, there is a perception that, it's hard for me to do. I'm too old. I'm too sick. There are some racial disparities that we've seen. Yes? Hematopoietic stem cell transplant. So, same thing as the autologous stem cell transplant. So, clearly, we think we can do more. And definitely looking at statistics, this slide is just showing, most patients with this disease are older than the age of 65 that are newly diagnosed, yet they're not being referred for this procedure. So that's something to think about. And, the oldest person we've transplanted at our center is 80 years old. And I think he got 3 years of good remission with that transplant. He's now 84 and continuing on with therapy. So just because you're old doesn't mean we can't do it. Again, you have to look for how healthy that person is and what kind of benefit that you're going to get with that procedure. So if one is good, is two better? Sometimes, yes. In some cases, we like to do a tandem transplant approach. This often works when, again, the first one is knock things down, but we still have some stuff left over. We want to knock it down again. It can increase the depth of that response, get you closer to the bottom of that iceberg. The problem is it is more toxic, so the more chemo you get, the harder it is on your body. But there are some other strategies being investigated. So one is giving more of that melphalan chemotherapy than we normally do. That can be very toxic, so it has to be combined with this drug called amifostine, which is it's kind of like a vitamin derivative that helps people get through the side effects with that. At the MD Anderson Cancer Center, they did a clinical trial where they added this drug called busulfan to melphalan, and they compared that to patients who just got melphalan. And they found that patients were in a deeper remission when you got both of those drugs. But there was definitely more toxicity, so we'll need that to be studied more. There are other ways where we can target the myeloma cells more effectively and where they live in the bones, like antibodies. They're like heat-seeking missiles, and we can put radiation on them sometimes and put them into the body, and they go to the bone marrow and deplete all those cells. So those are research areas that are currently being investigated. So to summarize here, the auto transplant side, an autologous hematopoietic stem cell transplant, long established treatment with benefits, continues to have a role even today. We can treat patients who are older. And then let's move on to the next topic, which is really what do we do after the transplant? Well, typically we do some form of maintenance. And again, the idea here is that now we've knocked it all the way down. We took a big hammer and we got you all the way down. We want to keep it there. And so considerations that we think about is how long do we do that? In general, we like to do that indefinitely. But there are situations where that's really hard to do, and so we don't always do that. How do we think about that in somebody who's not getting a transplant for whatever reason? Maybe they were too sick. Maybe we have to put in more drugs there. So what's the optimal drug? What's the dosing? What are the costs of these maintenance drugs? And most importantly, I think, is what is the cytogenetic risk? So what is the risk profile? And that often determines which drug, how long, what combination. So these are all things that you should be talking to your physicians about. So again, this highlights what I typically talk about in some of my initial consults, which is basically looking at that iceberg again. We want to get you down as close to the bottom as we can. And so we want to do that very quickly up front with intense therapy and then keep you here for as long as possible. So schematically, this just tells us what happens in patients. So what about allogenic stem cell transplant? This is that donor transplant. So again, the rationale for this initially came that once we realized that chemo and radiation could kill bone marrow cells, the idea was like, let's just go and nuke that thing and get rid of everything. And we'll just wipe it out off the face of the planet. Patients can't live that way. We'll just put in a new bone marrow cells from someone else. But that didn't really work out. But patients who had this procedure, some of them appeared to be cured of their myeloma when we did this. And they all had this side effect. When we do this type of transplant, you also inherit your donor's immune system. And the donor's immune system notices differences on the myeloma cells because it's never perfectly matched. And it goes and kills the myeloma based on identifying those differences. We call that the graft versus tumor effect. In fact, that's the reason we do these type of transplants for a variety of blood cancers like leukemia. It does work in myeloma as well. However, most patients with myeloma are older and they can't get this intense chemo and radiation. They just won't tolerate it. So once we realized that these type of transplants were really leading to cure by utilizing the immune system. We develop what we call reduced intensity transplants, sometimes called mini transplants. We can do this in older individuals, and it relies heavily on this graft versus tumor effect where the donor cells go and attack the myeloma. We're using the donor's immune system to kill the cancer inside the body. So, does this work? Yes, in some people. There are studies that suggest that this effect actually exists. We've had patients who are resistant to every type of therapy that we've tried. We do an allotransplant and we can put them into remission after the allotransplant. But there's a problem. Lots of patients continue to relapse. Sometimes this is slow over time, but it is a big problem. So we're not curing everybody with this. There are still people where it's coming back, and in the majority of the cases, it's coming back. Well, when we do this type of transplant, we get another side effect called graft versus host disease, because the donor immune cells, they don't just see the myeloma as different, they see the rest of the body as different. So all your normal tissues, like your skin, your gut, they can be attacked by those donor immune cells based on differences that they're seeing. And this is what we call graft versus host disease, and it's a feared complication of transplant, and it can be fatal. So there are new strategies that we need to control that and manipulate the immune system better. Dr. Matsui's group at Hopkins, they basically developed this technology where they give this drug called Cytoxan after the transplant, and that can lead to decreased rates of graft versus host disease. So people are evaluating these approaches in clinical trials, but right now someone asks me, a patient comes and says, should I get an allotransplant? I typically counsel them, well, you need to really think about that. We have to think about the situation, how aggressive the disease is. If someone's very young and can tolerate lots of chemotherapy, we think about it. But for older folks, unless it's done on a clinical trial, we typically don't recommend it. And that clinical trial often involves newer technology like the Cytoxan, or doing some form of therapy like Ninlaro or another drug after the transplant to try to help the transplant work better. But this type of transplant really was the birth of immunotherapy, and it is leading to this new type of therapy called CAR T-cell therapy, which I'm just going to touch on real quickly. And this is just a slide showing how this is done. We harvest immune cells, T cells, which we think are the ones that mediate that graft versus myeloma effect. These are the immune cells that actually go attack the tumor. We take them out of the body and we modify them. We put kind of a guidance system into them so that they can go and find myeloma and eat it. We expand those cells outside the body and then put them back into the body. And those guys are all like heat-seeking missiles. They just go find the myeloma. And these cells are like, it's like almost like getting a vaccine. They're going to live with you for the rest of your life. And as long as the target is on the myeloma cells, they're going to keep attacking it. So it's exciting technology, and it's in early phases, and something I think we're thinking about how we get here in Austin. So stay tuned. Hopefully in the next year that'll be coming. So I think I'm going to stop with that.